Good afternoon. This is Susan Lynn Osterly, the VBID Center Program Manager, and I'm pleased to welcome everyone to the 2021 VBID Summit. I'd like to take just a moment to go over some logistics. We'd like the summit to be as interactive as possible, and attendees can send questions and comments via the question bubble on the control panel. Now, I'm very pleased to introduce Dr. Mark Fendrick, the Director of the VBID Center, to start the summit.
Thank you, Susan Lynn. Good afternoon, good morning, good evening. It's a great pleasure to welcome all of you from across the U.S. and actually across the world to the 2021 Virtual VBID Summit. We are extraordinarily excited to celebrate the 20th anniversary of the first VBID publication and to welcome you all for a day to update you and let you know what's been going on in the world of value-based insurance design over the past score of years. Next slide, please. It seems like yesterday that that young guy to my left there, Mike Chernu, and I were sitting in this Korean restaurant on South University in Ann Arbor when we first articulated the idea of clinically nuanced or clinically driven cost sharing for an insurance product. And it's been really interesting as we reflect back today and also look forward that the inspiration for my work in this area. I hope something's not stopping my mother from showing up on the screen.
Sorry, you are breaking up. Hold on a second.
There's my mother turning 87 this month, who told me after I told him about Mike and my plan to do a research agenda around cost sharing. She said, "I can't believe you had to spend $1 million to show that if you make people pay more for something, they'll buy less of it." We're thrilled in our introductory remarks to have Amitabh Chandra, who will show once again that, like all of ours, my mother was right. Next slide, please. This is the flag head for the paper that Mike and I wrote with our colleague Dean Smith, who's on the line today. Value-based insurance design was called the benefit-based copay when it was focused only on drugs. As it expanded, thanks to Mike, he came up with the acronym VBID for value-based insurance design. Next slide, please. And since we launched the center in 2005, we're very pleased to have collaborated with multiple stakeholders across the entire healthcare spectrum to identify, evaluate, and implement strategies that improve access to essential care, putting patients first, enhancing equity, and hopefully reducing disparities, and ultimately improve the efficiency of the US healthcare system and perhaps some healthcare systems abroad. And we'll talk about a number of those initiatives today. Most notably, of our 20 years of impact and innovation, we'll touch on briefly our impact in the Affordable Care Act and preventive services, which, as Kavita Patel will talk about, is a gift that keeps on giving. The Medicare Advantage Value-Based Insurance Design Demonstration Project, which continues to grow in scope and implementation. Our work to reform high-deductible health plans to enhance access to people with chronic conditions. And ultimately, our work in low-value care and VBID-X, the creation of a cost-neutral VBID benefit design that robs low-value care Peter to pay high-value care Paul. And we're hopeful that this might be a new type of initiative that will allow VBID to move forward. I'd like to thank our sponsors who make all of our work regarding research, implementation, and policy work possible. Without this group, as you see from across the entire healthcare spectrum, we would not be able to do what we do at the VBID Center today. So I'd like to thank our sponsors. I would like to thank Susan Lynn Osterly and the VBID Center team for all their hard work for what the VBID Center does, and want to thank all of you for joining us today, our fabulous speakers, and importantly, my good friend and colleague, Cliff Goodman, who will moderate the discussion for the remainder of the day. Thank you all again, and Cliff, turning over to you. Have a wonderful summit.
Thank you very much, Dr. Fendrick. Glad to be here. Let's take a look at the next slide, please, which is our agenda. This is an overview. In a moment, you're going to hear a rather insightful bit on death by cost sharing, an interesting title. We're going to follow that with 4 special sessions, 4 panels. The first one's going to be on 2 decades of VBID policy achievements, followed by reflections from our early VBID adopters, and I might say notable pioneers. After a short break, we're going to get a consumer perspective, followed by an important manufacturer viewpoint, and then some closing remarks. So a lot to get through here today. I want to go to our next slide as an intro. We're going to have these opening remarks addressing this interesting issue of death by cost sharing. We're going to hear next from Dr. Amitabh Chandra. He's a bunch of things. He's a professor of public policy and director of health policy research at Harvard's JFK School of Government. He's also a professor of business administration at Harvard Business School. He does a little teaching on the side and a bunch of other things as well. So Amitabh, it's great to have you in this very position. What in the world do you mean by death by cost sharing? Over to you, sir.
Wow, thank you so much, Cliff. It's, you know, I've been in this business for exactly 20 years. I've been a health economist for 20 years, and this is the first time that I got invited to come and present. So it's such an honor for me because I've been following in Mark and Mike's footsteps for 2 decades. I did not know the story about Kang. I think it's very appropriate that you all started at Kang. My Korean friends tell me Kang means strength, it means resilience, and you guys have been at it strongly and resiliently for so long. So I'm going to share with you a brand new paper that I did with my research assistant, Evan Flack, and with Ziad Obermeyer, who's a physician and data scientist at UC Berkeley. Next slide, please. And what we're going to ask is a very simple question. We're going to ask, you know, what happens to people's mortality when they face cost sharing? Now, for most economists, nothing happens to people's mortality when they face cost sharing. I think the standard view in economics is you face cost sharing, you cut back, and the cutbacks that one observes were wasteful care. But of course, I mean, I think most of us have always had the sense, most of us who are physicians, most of us who are sort of on the behavioral side of things, that like this cost sharing could harm patients if patients are cutting back in a very haphazard way. So if they're cutting back on a haphazard way, it could be the case that they cut back on very valuable medicines, in which case the spending that we, you know, the less spending we have, the savings are actually not the savings we wanted because we've harmed lives. There's lots of reasons to think that people don't know what to cut back on. I mean, if you think about just a simple math problem, we have a patient on 5 drugs. The patient faces cost sharing. What should they do? Well, the patient has to sort of figure out which is their most valuable drug, their second most valuable drug, their third most valuable drug. And there's 120 different ways in which you could rank 5 drugs, right? And the patient never went to medical school, not to mention that I don't think most physicians would know exactly how to rank these 5 drugs. So there is a growing literature on behavioral hazard. Back in 2010 with John Gruber and Robin McKnight, we found that very small cost sharing, just $5 or $10 of cost sharing, was causing patients to cut back on valuable drugs and land up in the hospital. We weren't able to look at mortality, and the response to our paper was, well, you're showing me that cost sharing gets people into the hospital, but they don't necessarily die, right, as a result of that cost sharing and that hospitalization. Nitish Chowdhury did really important work in the New England Journal of Medicine, where he looked at men with heart attacks and showed that, you know, for men who have just had a heart attack, so these are some of the most activated patients in the world, when confronted with cost sharing, they don't take valuable drugs that would actually prevent another heart attack. In some new work that I did with Zarek Brott-Goldberg, who is an assistant professor at the University of Chicago, Ben Handel and John Kolstad, who are economists at UC Berkeley, we found that when we move even high-income people into a high-deductible health plan, it does not look like they're acting the way economists thought they would be acting. For example, they're cutting back very haphazardly. They don't use any of the price transparency tools that we give people. So there was a sense, I think, that all of us had that the cutbacks that cost sharing induces might not be the cutbacks that we really want from a public policy point of view. Next slide, please. So then the question becomes, what about mortality? What about the health implications of cutbacks? And I think there's 3 reasons why we have not been able to do this quite as easily as we would have liked. The first is, it's very hard to study the effect of price increases on health because prices are not randomly assigned. So if you were to say compare people who fell into the donut hole in Medicare Part D to people who were just before the donut hole, it will look like the donut hole really kills you, right? But you have to be sick enough to fall into the donut hole. So is the donut hole really killing patients? Or is it that you were sick enough to experience a donut hole that was causing patients to have higher mortality? We don't know. So you need a design where patients are sort of being randomized into higher prices and lower prices. Mortality is also very, very, very rare, thankfully, right? So in our study, we're going to look at mortality in 65-year-olds. It runs at 1%. So 1% of 65-year-olds die every year. And to detect a 10% increase in that 1% mortality rate, I would need to randomize about 325,000 patients, right? That's a really, really big study. The treatment group in the Oregon Health Insurance Experiment was 9,000. In RAND from the 1970s, it was 5,500. So I think that's one reason we've always wanted to study mortality. It's very hard to study mortality. And so we've been studying cutbacks. And the problem with cutbacks is when physicians see patients cut back, they often say, well, it was high value care that they cut back on. When economists see patients cut back, we say, well, it was low value care that they cut back on. So the studying cutbacks in care is really a very crude, fairly insufficient, blunt way to get at what's going on with patient welfare, right? We want to know when you cut back, what's happening to your health. Next slide, please. So that's what we're going to do in this study. We're going to look at people who are exposed to the donut hole in Medicare Part D, not by comparing people who fell into the donut hole or who didn't, but for people who were randomly exposed to the donut hole by virtue of the month that they were born in. What am I talking about? Well, as many of you know, in your first year in Medicare Part D, when you're 65, the thresholds for the donut hole are not prorated by whether you joined in February or September or October. So someone who was born in February, enrolled in February, is much more likely to be exposed to the donut hole than someone who was joining in September. So that's what we're going to be working off of in this study. What do we find? We find that exposure to this donut hole, right, induces a pretty big price increase. We've known this forever, right? Prices go up about 30%, 33%. It's about an increase of about $10 per drug. What does it do? Well, it increases mortality by 30%. Now remember, baseline mortality is running at 1% for this group. They're all 65-year-olds in our study. So the 1% is becoming 1.33%. That's how you should think about this. Now, I think my economist colleagues on the call will say, well, maybe this was all rational. It would be rational if people were valuing their life at approximately $6,500, $7,000 per year. I think most people, most of the literature would say people tend to value their life somewhere between $100,000 to $150,000 per life year. So yes, you could square it with rationality, but you can only square it with a peculiar form of rationality where people just put a very, very low value on their lives. We find that patients drop life-saving medicines. So they're not just cutting back on drugs where we don't have good clinical evidence, but in response to these $10 copays, the drugs that people are cutting back on are statins, blood pressure meds, where we have very good RCTs that they will keep you alive. We see people in high-income zip codes respond identically to people in low-income zip codes. So this is not just a story about liquidity, this is a story about information. And interestingly, we find that about 20% of patients are more likely to just not be on any drugs. Now let's think about that for a second. We thought that patients would cut back on their drugs. If I'm on 5 drugs, maybe I drop to 4 drugs. If I'm on 4 drugs, maybe I drop to 3 drugs. And maybe I do that incorrectly. What we're seeing in the data, though, is people confronting this very complicated high-dimensional choice problem are sort of retreating from the choice problem completely and dropping to 0 drugs. Well, when you go from 5 drugs to 0 drugs, that's probably going to have really, really big mortality effect. So that's, I think, the behavioral driver behind it, is that there's some cognitive scarcity when people confront these very complicated, decision problems, and some patients just disengage. So, the takeaways, I think, are not that surprising for all of us in this room. Small changes in cost sharing generate very large mortality effects, which were probably not detected before, simply because no study in the past, be it RAND, be it Oregon, really had the kind of sample size to be able to detect this. We're not saying patients don't respond to prices, just to be very clear. We're saying patients do respond to prices. In fact, they're too responsive to prices. And I think that's that's a real opportunity for VBID designs, because if you can get them to respond to the right price, they will respond to the right price. I think that one of the things that we take away from our study is that there's a real opportunity for VBID, not only to put sort of high copays on some drugs and low copays on other drugs, but to have high copays for the patients who would benefit less for the drugs, and low copays on the same drug for patients who would benefit more. So we roll out a machine learning algorithm that allows us to sort of ex ante identify these patients. And I think of it as this idea being much closer to the original formulation of VBID. VBID nowadays gets used a lot to, say, make preventive treatments free. But I think the real uses of VBID are to make the drugs that are really, really valuable very cheap, and make a variety of dubious drugs and dubious treatments quite expensive. And so I think we want to kind of go back to that original conversation at Kang Restaurant. Next time, maybe Mark and Mike, you will invite me to accompany you, because I think that conversation, which is now 20 years old, I think we finally caught up to you in terms of the machinery that's needed to get at the vision that you hatched 20 years ago. And thank you again to everyone for listening and for inviting me to this. The paper is in the public domain. You can download it at the NBR. Thank you again.
Amitabh, thank you very much for setting this up so well. And in particular, your takeaways are capital T takeaways, the aspect of large mortality effects that caught my attention. And then kind of the nuance with regard to response or non-response to prices. But it really sets up a large or even larger role for VBID to identify which patients will benefit most. Again, I'm hearing echoes of nuance along the way there. So Amitabh, swell setup. We really appreciate it. We're going to bounce a few of your points off of our panelists later today. Thank you very much.
Thank you.
Okay, you got it. Thank you. Let's move to our first session. And this is about 2 decades of VBID policy achievements. We are going to look back a little bit, but if you have 4 all-stars like this on your panel, you're also going to have them look ahead just a bit too. And so just to jump right in, I'm going to start with Karen. And the question is for each of you, a quick self-intro, and then how'd you get pulled into this? Very high level, Karen, who are you and how'd you get pulled into VBID?
Thanks, Cliff. Karen Ignane, CEO of Emblem Health. We are a regional health plan located, domiciled in New York City. When I first met Mark and Mike, I was in DC at AHIP, and we had a laser focus on affordability at the time, not unexpectedly. And what Mark and Mike were encouraging us to do is to step back and think about ways to redesign benefits to bring people into the system, not inadvertently keep them out. And I thought our previous speaker's presentation was just terrific in that regard. So this was a whole new way, a whole new mindset, a whole new way of thinking about things. Not only did it catch our attention, but we immediately signed up and signed on to be part of this quest to really rethink and redeploy. So that's how I started.
Thanks, Karen. So basically that was your hook then.
That was my hook. The guys were my hook. We said yes right away.
All right. Well, we're all lucky you did say yes. Thank you very much. Let's go to Jim next. Jim, how'd you get pulled into this? And that's our buddy Jim Parker. And there he is. Hey, Jim, how'd you get pulled into this? There you are.
Great. Well, I got pulled into this in a variety of ways. Most immediately, it was through an experience working within a large national health plan, where we saw the influence that benefit design had on member behavior. I also saw it from a different perspective when I was working within a large integrated healthcare system, and we saw how benefit design influenced provider behavior. If there was a benefit for a procedure, it was much more likely to be recommended than if it was not. And then most recently, from my perspective at HHS in the policy world, we saw and had the opportunity to really influence the advance of value-based insurance design, which we're very proud to be a part of.
Well, thanks, Jim. So basically, you had two hooks, an earlier one, and then moving over into HHS, there was another opportunity for you to really capitalize on this. So thanks, Jim. By the way, I'm going to plan a little thought with you. Sometime later, you're going to tell us about the IRS connection. There's a cool IRS thing that you know about. We're going to call on you for that. Kavita Patel, thank you very much for joining us. Knowing you, it was either a call from the White House, an appearance on MSNBC, or you were seeing patients. Which was it today, Kavita?
Yeah, the first two are being overly generous. It was the last one. It's my happiness to be able to take advantage of the value-based insurance design in real life and tell people that they can get a lot of these exams and services for free. So that's a good thing.
Great. Well, and in line with our conversation, Kavita, how'd you get pulled into this? What was the hook for you for this?
Yeah, I was trying to remember. I think it was 2006, 2007 when I first met Mike and Mark, and to credit to someone who hopefully is the audience will hear from, Katie Spangler, who worked then for Senator Enzi. I worked then for Senator Kennedy. And there were a lot of acronyms being thrown around, and VBID was one of the few that I actually understood, unlike a lot of the other acronyms, and saw the growth from, something that seemed like a good idea in the commercial insurance market, to Karen's point, to really finding a path forward. And I'll just put in a plug. I think the five of us remember the battles over the ACA pretty well, but it's funny how many people I meet who that's just a distant memory, or they never really understood it. And so I'm excited that Section 2713, my favorite part of the ACA, which is probably one of the most under-recognized parts of the ACA, but in my opinion, especially as a doctor, I think we can agree it's probably the most important part for delivering on the promise to get preventive care, preventive services, and starting to get upwards of 100 million Americans kind of necessary screenings for important things like lung cancer just recently, colorectal cancer. So it's very exciting to kind of watch the journey over all these years.
Yeah, thanks, Kavita. And lung cancer just this week, pointed out, and 2713 has been your and our lucky number, by the way, I'll say that. Over to Patrick Conway. Patrick, you've had a couple instances to be pulled into this. Can you just tell us briefly how that went about?
Yeah, so the very first time was about 15 years ago when I was a RWJ clinical scholar and learned of Mark and Mike and the work on VBID, and then got to luckily continue it at CMS with the Innovation Center with the VBID demos and other things. Actually brought me back. I forgot about lung cancer screening. I was chief medical officer at CMS when we did the first coverage decision on CT. Which is a little more controversial then, hopefully less so now. And we actually put in all the preventive coverage decisions so everything could get covered and paid for free. So it's bringing me back to my chief medical officer days, and then, continued that through different roles at CMS and then in Blue Cross North Carolina, and now at my role, CEO Care Solutions at Optum.
So you've really done a couple stints in government and now back in the private sector, and it has retained its relevance apparently.
Yeah, it's definitely relevant across the public and private sector. And I agree with what Kavita said. I think a huge impact in the public and private sector. Some people recognize fully, probably some people less recognize fully. But I think a large impact across the public and private sector, and been able to work with Mark and Mike and others to try to implement some of these things, both in the public and private sector.
Great, thanks, Patrick. Now I want to come back to Karen, and now that you've introduced yourselves as how you got hooked, you are also pioneers. So Karen Ignani, what was it that you and your organization did to advance the field, to really get it ramped up? Karen?
It's a really interesting question, and I was so happy to have a preview for this question because it gave me an opportunity to think. When I was thinking about how I got involved in VBID and what we did in DC to now, this is Cliff, if it's okay, what I'd like to talk about, because moving from the policy world to a world that is more architectural, if you will, we've had the opportunity to put 3 examples of VBID in practice, and I'll be very quick about it. The first is we work with the City of New York and its unions to create a whole New York City Gold program. And it's built on VBID concepts, where a major push toward, to Kavita's point, robust preventive services, but also rewarding and incentivizing people, not in a negative way, but a positive way, to actually act on those incentives. And we can come back to that because I think that's uncharted territory that could be very productive. But we also embedded coaching to help people with lifestyle issues, chronic illnesses, and so on. We embedded care management and centers of excellence. So it's an end-to-end VBID relationship with our customer. And in that sense, we can follow people from the early stages through the latter stages of illness and do everything we can on the front end to keep them as healthy as possible. The second example is we actually created a national company called WellSpark to focus on this early invention in investment in prevention and coaching in particular. And I know my colleague, who's the CEO of WellSpark, Bert Wachelhausen, is listening and participating in this event. But she's really focusing on how can we take these early stage, particularly in the area of coaching, food. We know food is a very big part of people's health status, their lifestyles, et cetera. And how can we do as much as we can early to prevent things down the line? And she has some great data, which Mark has actually partnered with Bert on, to really show the efficacy of this investment. The third example, we've stood up 12 community health care centers open in some of the most underserved neighborhoods in New York, open to all people in those neighborhoods, not just members of ours, where we're also helping close gaps in care. We're helping with food insecurity, transportation, behavioral health, but really unlocking that door to the healthcare system and supporting them in that regard. So we're looking at it through a variety of ways, but it's been such a pleasure and an honor to have an opportunity to kind of morph from a policy role to one of implementation and partnering with terrific people to do that.
Thanks, Karen. And what strikes me is that not only the breadth of application, but your attention to timing of intervention with VBID. So there's a multidimensional aspect to that that kind of came across in your remarks. Thank you. Very, very helpful.
No doubt at all.
Great, thanks. Jim Parker, you were in a couple roles to help advance the field. Tell us just a little bit about how that went.
No, glad to. Let me start by just sharing an experience I had within IU Health in Indianapolis. They launched a Medicare Advantage plan. And as a large academic medical center, they just naturally attracted individuals with complex health conditions. And we were really excited for the opportunity to bring those resources together to help those individuals lead the healthiest lives they could. But what we quickly discovered is that the Medicare Advantage benefit requirements didn't always help us the way we wished they could. And specifically, we experienced that with respect to congestive heart failure. We weren't able to effectively monitor those individuals remotely without providing the same resources and capabilities to all of our members. And so we were delighted when, in fact, CMS and perhaps Patrick and CMMI came forward with the the original VBID demonstrations. And we immediately applied for those. And we're just ecstatic that we had the opportunity to apply a VBID model in a very hands-on way with those members.
Thanks very much, Jim. And it's interesting that you had a problem in your on your desk, as it were, about complex conditions, comorbidities, and so forth. CHF is a good capture of that. People that have CHF don't only have CHF for that matter. And then along came VBID. And since you mentioned Patrick, why don't we go to Patrick next? That's a very nice connection there, Patrick. So how was it, whether it's CMMI or elsewhere, that you advanced the field?
Yeah, so it's thanks for the reference, Jim. We did, building on the work of Mark and so many others at the Innovation Center. We began talking about having a demonstration on VBID focused in the MA world, both Part C and D, as Jim described. That demo launched. It did have positive effects in terms of steering people to high value services and away from low value services, had positive effects on Part D plan bids. As with all demos, you learn. There's aspects, Mark and I have talked about this, there's always CMMI models. If you've been the director of CMMI, you know that there's parts that you get right and parts that didn't come out quite the way you expected, but you learn from all the interventions. And so I think it was a good positive example, and then really led to broader changes in the CMS program, in the Medicare Advantage program that were embedded across the program that now private sector organizations get to take advantage of and drive better care for people at lower cost and value-based insurance design broadly in the private sector. So, I think it's one of these aspects of our health system that we've seen a long positive trajectory built on the work of many people on this panel, on the panels today and others, that's had a positive impact on people's lives in terms of better health quality and lower total cost of care.
Thanks, Patrick. Well, you certainly came along in time to help Jim Parker, among many others. And maybe a little bit later, if I could just plant an idea, and that is, what was it about the experience that you had at CMMI in the context of what's gone better and not so well at CMMI that is a carry forward for the future of VBID? We'd be interested in your views on that. Thank you. So Kavita, back to you. You already mentioned 2713, why that was a lucky number and so forth, but tell us a little bit more about your role, or maybe roles, in advancing the field early on.
I think we couldn't have anticipated, something like the Affordable Care Act. So there were actually several attempts at trying to, of course, initially through legislation, but then, I think Patrick was right when he was chief medical officer, working both with the Bush administration and then kind of continuing it on through kind of the beginning of the Obama administration, trying to figure out what was the kind of context and the right way to think about value-based insurance design. And even more basic than that, I think people really couldn't wrap their heads around, how to think of what I think are now a little more familiar with, which we would call like low value or high value care. And Amitabh kind of hit on why some of these designations are important. It makes sense to people clinically. It makes sense to economists, policymakers. It's really hard, though, to kind of put broad scale policy together. So it was important at the same time to have VBID in the preventive services area, and especially with the Affordable Care Act, to think about it in the context of something like the United States Preventive Services Task Force. And there was even a debate, I remember very clearly, Patrick and Karen probably do too, all in separate circles about, was it level criteria of a grade of an A and a B, was that good enough? And then if something got a C, did that mean that we wouldn't try to cover it? And that was just in preventive services. We did try to go a little further, and I think people saw, and I still do, which is why I think Patrick worked on the demo part of this, and that was very necessary, because we knew that preventive services should not be the full scope of where VBID has promise. And there were some important studies done early on out of CVS and other places where they gave away medications for hypertension and other chronic conditions for free, and made kind of visits, zero copay And I think that was the spirit where we were trying to understand, like, if there is a high value healthcare service, i.e. taking care of a diabetic and doing all the things that are involved in routine maintenance of a diabetic, how can we make that completely, how can we take away any restrictions for doing that? I do think that, to Karen's point, the commercial insurers, Patrick at Optum and at the Blues, people are trying, that's the spirit with which I think everybody is trying to move kind of VBID into reality on a day-to-day basis. It becomes a little bit more complicated when I'm seeing a diabetic and then I'm also taking care of something else. And because of just, honestly, even though our coding has come somewhat far, it hasn't come far enough. And we're still kind of bound within like these very crude constructs of E&M coding and levels of visits. And I was joking the other day, we don't even have an ICD-10 code for some of these COVID-related sequelae, which we're seeing a lot of. So that is where I think the complexities occur. So I started working on this from a very like legislative, high level, and then, you know, as you see that process move from regulatory into action, you start to understand that it's just not as easy as you would like it to be. And that one person's high value service might seem like another person's low value service, but the goal is all the same, to make sure that there are no barriers to kind of the care that we want to provide. And COVID has taught us a lot. Like, I really do think that, like this morning, a lot of my care can be done virtually for many conditions. And if that can help to deal with the cost kind of issues that Amitabh brought up, I'm all for it, you know. And it'll be a challenge, I think, for insurers who are trying to figure out, including Medicare, what's that right size of a balance in taking away kind of barriers and how to deliver high quality care.
Kavita, since you mentioned COVID, and since you always talking on TV about vaccines, is there any connection between COVID vaccines and 2713?
It's as if Mike and Mark were in your ear. Yes, that 2713 in the ACA, and thank goodness the ACA has stayed mostly intact since then, is like literally the law that was used to allow for COVID-19 vaccines to be given for free. So it's just one more kind of example. Like I said, it's one of the most underappreciated provisions in the ACA. And as I think, I mean, I'll tell you right now, in the DC area, obviously, and I'm probably in everybody's home states that they're in right now, demand is way higher than supply. Supply is coming, but we can't fill, you know, we can't keep an appointment open long enough. People want the vaccine so badly. So yeah. It's been great to see that. And it's funny, people still say, are you sure this is free? Like, they just don't believe it. So it's kind of a, you know, and people are, I'll just say COVID testing is free also. And yet we see some examples, which are kind of our policy, like to-dos around surprise billings. And, you know, navigating the insurance system, navigating the health system is still hard. COVID showed the country that it's pretty hard. And it's nice to be able to deliver on like distributing vaccines and actually putting them into arms and telling people, no, this is for real, this is free, you know. It's pretty amazing.
That connection, though, to VBID in 2713 may not make the headlines in the big newspapers, but among us folks on this call, we know it and don't take it for granted. So thanks for reminding us to ask about that. Karen, just back to you now. I want to kind of move into sort of VBID applications henceforth. And maybe with regard to the delivery system and how it's organized, or other sort of intersections with the healthcare sector as you see them, how is the VBID role evolving for the future? Karen.
I think this is a really important question, and I appreciate your asking it. I think there are several things to keep in mind, and Kavita said it, I think, particularly well. As we talk about high value, low value, my perception is going to drive what I think. And I think more research around that to get to a preventive task force status on how do regular people process the value equation? What should they keep in mind? So this is third-party research that could be assimilated by individuals, and they would feel that it's reliable. That's number one. So I think more is needed there. I think, two, what we're finding is there's so much opportunity, not just in the area, we say prevention in the healthcare area. And unless you're a clinician, I think, and Kavita, you talk very compellingly about this, I think people don't have in their mind exactly how far that can go. How do we change lifestyle to actually deal with chronic disease? What's necessary in that bucket of prevention? We're particularly excited with the work that we've been doing with the City of New York and its unions on the impact of having a coach if you have diabetes. And how does it affect your compliance with drugs? How does it affect how you eat and what you think about before you put something into your mouth? And food is a very big part of that. And I know we're broadening the definition of health to think about social determinants in food, but I think this is really important for VBID and prevention and that whole area. I also think talk therapy. We don't think, I mean, these are now important. People have gone through such a difficult year, to say the least. And we could talk for an hour about how difficult this has been for a number of communities, particularly communities of color, where they've been just slammed by COVID. And talk therapy is something that we're finding is particularly appreciated, used, and beginning to be highly valued by individuals. And I think goes along with everything Mark and Mike challenge us to think about, but it enlarges the lens a little. And then finally, I think connecting VBID to population health. And in the policy community, all of you who are on this panel and the panels that will be coming next, think about the intersection. But I think a little more work and discussion in the policy community as we think about population health, which is a moniker that people, people genuflect at the altar, but they don't really necessarily embrace the comprehensiveness of it. And I think VBID fits beautifully into population health. You can't improve the health of populations without really thinking about the benefits, Maslow's hierarchy of needs. So where do you start, where do you end, and what's the end-to-end strategy?
So Karen, just to help us understand a bit, you mentioned, for example, talk therapy.
Yep.
Sounds cool. We see that might be the right time for it now, given what we've all been through. What's the VBID connection? Are you talking about kind of making that a pre-deductible service? Are you talking about making under a preventive? How does it fit in?
Yeah, as you think about prevention, if you accept the proposition that coaching is valuable, and we're not only finding that, but proving that, then I think you really think even bigger. And I've learned quite a lot from my colleagues at WellSpark that are on the front lines of all of this. And I think this is a part of a brave new world for patients. We see, as part of our enterprise, we have 41 medical practices, primary and specialty practices, located in all of the underserved communities in New York. And what we see is exactly what Kavita was talking about. People are really excited about getting our ability to get vaccines into their arms, but we see all of the challenges that people face day to day. So it's, as you step back, look at the benefit structure, thinking about it in a little more modern way, Cliff, enlarging the lens. So it's not to say everything that we did in the past, that Patrick did, Jim did at the agency and elsewhere, and that Kavita's doing now isn't correct. But it's, I think we can take these concepts and really continue to build on them. So I think the point I'd like to leave you with, VBID is something that was started by Mark and Mike 20 years ago. And now I know it was at the restaurant. I didn't know that story. But I think that as we now are out, particularly with the pandemic, and looking at valuable services that we can bring to bear that in the long term do save money for patients, but require a much larger upfront investment, I think it's worth talking about that.
So this is basically a call to broaden the scope of potential services to be subject to some kind of VBID arrangement.
And putting it into a package.
View. Right.
Exactly.
Got it. Good.
Yep.
Thank you. Jim Parker, so in your current role and looking ahead, where is VBID or should VBID be woven in? Where do you see it, Jim?
Well, I must say, I find myself in probably violent agreement with Karen. I think the natural progression of value-based insurance design takes you to a level of decision-making and treatment decisions supported by effective benefits that really focuses on the personal needs of the patient. We're seeing this, in many, particularly in the Medicaid segment around social determinants, as Medicaid benefits are being broadened to include, what we would consider to be non-traditional benefits, but nonetheless have real impact. Pardon my dog. Real impact to the individual. As we do that, I think we're going to completely redefine how we think about benefits. In the world of the 20th century, health plan benefits, in fact, there was a time when they were actually scheduled. And they were scheduled by site of care. If you had a hospital admission, you got this. If you had a physician's office visit, you had that benefit. That was the most effective way to share in the financial liability that individuals were incurring. As we've moved to benefit designs that focus on medical necessity and more so focus on the well-being of the individual, it's really forcing us to rethink how we tailor benefits. Certainly in a broad scale way with respect to preventive care that we know is effective on a population basis, but even more so at the individual level. What level of benefit would be most effective for this individual? That's going to be really hard, but I think that's directionally where we're being taken.
Well, it sounds like, Jim, you and Karen are taking us to a place that recognizes that the pandemic has shaken us up a lot in many ways, and that it is an open opportunity to consider benefit design, broader, more encompassing benefits to which some sort of VBID application would be appropriate to enhance access. Sounds like a plan. Patrick Conway, in particular with your current role at Optum Care and so forth, how do you see VBID being woven in, and are there any carry forward lessons from the CMMI experience that might apply? Patrick?
Yeah, I'll do quick North Carolina example and then do Optum. Coming out of CMS, applied VBID into Blue Cross North Carolina. The most simple example, we started something called Smart Shopper, which was literally green, yellow, red around VBID design services, 6 to 7 ROI, drove major decisions like where you get your MRI, which service you want. So both site of service and then adopted by other Blues, not all Blues, but a number of other Blues. So I think tangible example right after CMS in North Carolina. Here at Optum, a huge opportunity to apply. So we deliver care to over 100 million Americans in some form or fashion across multiple payers, everything from primary care to specialty care to behavioral health, which was just mentioned, to social determinants. And so as we do that with now over 55,000 doctors, over 70,000 clinicians, we're trying to think about how we build a system that clinicians work with patients and people and get them to the right high value services, try to avoid low value or no value services, and how we achieve the quadruple aim. I mean, that's the goal of what we do each and every day. And we do that. I have a program called Optum at Home that is now for dual eligibles, full risk care delivery in their home, mental, physical, and social, all of their needs all the time. And it delivers tremendous results in terms of star ratings and total cost of care and experience, because we surround people with the care they need in a population health framework. So I think that's where you see the future of this going.
Patrick, you're in a competitive business, you're a big player, but it's highly competitive. Is there some sort of competitive advantage to pulling in VBID and or looking at low value services in your realm?
Oh, definitely. Yeah, I mean, definitely. And Optum's an interesting we touch a lot of parts of healthcare. So it's both competitive advantage and I'd say partnership opportunity. I'm sort of a natural partnership thinker. So Optum partners with various entities in a lot of ways, health plans, health systems, et cetera. And so, but I think, yeah, I mean, the VBID is a critical enabler of value-based care, achieving the quadruple aim. So, I try to be a systems thinker. So then you think about how do you put these interventions and this evidence into place systematically, measure the results across populations of people, and continually improve.
Got that, which makes you more competitive after all. So before I come back to Kavita, Jim, I just don't want to let it go by. Tell folks what the IRS connection is, why that's an essential piece. I don't want to kind of miss that, Jim.
Well, very quickly, I got a call from the IRS, but it wasn't.
Sorry to hear that.
Might expect. It was a good call, and it was an opportunity to sit down with the IRS to discuss expanding the range of services that could be included in a high deductible health plan benefit without having to exhaust the high deductible. And I know that, in fact, that was my first personal introduction to Mark, and it really catalyzed our thinking around what we could do. And so the good news is that through the work of the VBID community and the collaboration that we had with the IRS, we were able to significantly increase the number of services and technologies and devices that would be available to individuals within high deductible health plans before they exhausted their deductible.
So important theme here, and that was a very important historical benchmark, underappreciated but highly significant. The same thing as 2713. Listening to Karen and you, Jim, and Patrick, the way you've kind of described your interests or your business, as it were, a lot of this has to do with where might you expand selectively and targeted benefit design, and embracing VBID as a way to enable that. So I hear a theme on that. So Kavita, back to you. And if I could ask you to put your clinician hat back on and thinking about how patients see their pre-deductibles and copays and all that, and how that is changing, what do you see henceforth for the patient experience emerging from the pandemic that might reflect on VBID? So you're a clinician, but your policymaker hat as well, Kavita.
Yeah, I think the probably more clear kind of 2021, 2022 outlook is really around having people even understand that these are benefits. I mean, it's still kind of frustrating for some of us that for reasons that are kind of complicated, but some just come down to, as much as we've tried, Karen did this at AHIP, everyone's tried to improve kind of health literacy, health insurance literacy, more specific, and simplification of EOBs and all these things kind of are important, but they're necessary but not sufficient. So I do think that having, whether it's through these more proactive outreaches, kind of Patrick talking about embedding people, what we end up doing is concentrating on kind of the most high risk or some of the more high cost populations. So, the kind of top, 11% accounting for about 72% of cost in some cases, in some markets. And that's where we tend to throw a lot of solutions. And I think the future, or at least the presence of VBID clinically, is kind of going below that. I mean, it was something we've been talking about in our clinics. Can we use the opportunity with COVID and the vaccines? Can we use it as an opportunity? And we're doing it in some settings to do simple screeners or to do some simple education. One of which is that, for example, you can get your FIT test or a screening colonoscopy, a screening mammogram. There are still some policy issues, because if your screening colonoscopy becomes a diagnostic colonoscopy because they find something, it's not free. And there's been legislative movement. There's been a lot of interest to try to remedy that, but nothing's ever that straightforward. So I do hope that it comes with a more heightened awareness of opportunities, certainly for high cost patients, to be able to do as much as we can so that their disease and their outcomes are better. But then we've got a huge bulk of people that are kind of in that middle of the pyramid, and they're right on the cusp, and we would love to kind of figure out how to be more proactive and get services. It's what makes attractive sometimes these, you know, coming out of CMMI, there's direct contract. There are these new models that are coming out that I think just push providers a little bit more, push doctors even more specifically into sub-capitated arrangements. And I think that can be, in some markets that works really well if you've got kind of a foothold and you've got these like disruptors. In my market, in like the Mid-Atlantic area, it tends to not necessarily achieve the scale we want it to. So I do look to places like CMS to, there's been a lot of debate about mandatory kind of regional participation. I think we're going to have to see that in order to kind of see the follow through on VBID. And so clinically, I think patients are still going to be asking a lot of the questions. I'll be honest, I talk to way too many doctors who don't understand what some of these benefits are still to this day. So there's education to go around. COVID has exposed the need for that. And hopefully because of the push towards some of these models, whatever you want to call them, alternative payment models or doing things like primary care differently, we'll see better kind of interest and adoption, both at the patient level, but also at the provider level.
Well, it's interesting. In a way, it sounds, Kavita, like even under today's circumstances, there's a lot of headroom for improvement. Patients aren't even aware often about what advantages there are and what services may even be available to them at little or no cost.
Yeah.
So there's that educational component, right?
And it has to do with, we have, for a lot of reasons, we have kind of defined enrollment periods. And, you know, I probably all of us can share our experiences with getting, you know, kind of the HR email with the different plans. And here's the PDF and the comparison, which by the way is, you know, also like the ACA pushed a lot of that and forced a lot of that simplification, so to speak. But I do think that it's confusing and people don't quite, you know, it's very difficult to get people to kind of engage in their healthcare when it's enrollment period and they're not kind of in an immediate need. And then it's very, very different when what we like to call the point of care. Statistically, if I want to get a patient of mine to stop smoking, my best chance is on hospital discharge, not with me hauling him or her back in and telling him to stop smoking and like pointing my finger. Same thing with weight loss. But we have to be there at the right time to kind of capture that. And then we're not even, I mean, a very lengthy debate in the popular literature about why countries like India and Africa have not been hit by COVID as hard. Lots of theories, temperate climates, et cetera. One thing that was very obvious to me is we don't have as much obesity in those countries for a lot of different reasons. But when we look at the severity of obesity here, so, you know, will we tackle that and take that on meaningfully? It'll involve some of these principles we talked about.
There's still a lot of upside opportunity, even kind of low-hanging fruit in this area. Absolutely. Just a time check. We're going to go to 5 minutes after the top of the hour. I'm just letting our next panel know. So, and I've got a closing question here. And Karen, since you've been such a great leadoff person, I'll start with you. And just to answer in a minute or so, and that is this. All of you have been early adopters and pioneers in VBID. What would you tell the next set of people who are interested in VBID? Look, if you really want to help take this to the next stratum, the next level, okay, some kind of meta VBID, here's what you need to make happen. So this isn't even what you're doing today, Karen. It's like, what should that next set of people who want to climb into VBID and make something of it, where do they need to take it? Future, 1 minute, Karen.
It's a great question. I think Kavita and Patrick, the combo of their answers, really give us shine a spotlight on the answer to your question, Cliff. I think we need to begin to think bigger about the concept of prevention, high value care, and really morph it into, enlarge the lens and start thinking about lifestyle benefits. That is the key to unlocking, I think, good health. Prevention is part of that, only a part. Food, exercise, lifestyle, social determinants, behavioral health, all part of it. And I think the policy community is beginning to evolve there. And my colleagues did, in addition to Jim, a great job of really laying the fundamentals for those discussions, I think, in their comments.
So take it wider, prevention, food, lifestyle, and so forth. Again, that theme of expansion. Good. Jim Parker, where do we need to take it next level?
Well, first I would say two things. One, you can't be afraid to experiment. And in doing so, if you need to, just identify a specific issue you want to get your arms around, do that and learn from it. And then, where you've misstepped, correct, but keep going forward. But more broadly, I would also say that so much of the issues we face have to do with just the general state of health in the U.S. I found myself nodding as Kavita talked about the rate of obesity and diabetic incidents in the U.S. I think that has a lot to do with the experience we've had during COVID. And so there needs to be a real focus, not on what are the benefits we're going to provide when someone has demonstrated that they're ill, but what are we going to do to cut that short, to emphasize and promote a state of wellness.
Got it. Thank you very much. So just briefly, let's go first to Kavita and close with Patrick. Kavita, just a sentence or two. Next generation VBID, where do you want it to go? How do we take it there?
Yeah, I think the next generation, just very briefly, kind of getting to those high value services, but being able we had the USPSTF as a way to do the preventive services. But I do think that now we've evolved and it can be pegged to some of the very kind of traditional HEDIS measures, ratings. I mean, we can come up with a creative way to align progress we've made on quality where we know things matter and be able to kind of put that into place. It is being done in commercial settings. I think employers are also incredibly interested, but to me, seeing it push through into the public payer side, whether it's MCOs or Medicare fee-for-service. So that would also mean to me, I like it when things come out of the CMMI kind of bucket, and Patrick knows this well, the threshold, it's actually not as crazy as one might conceive to then kind of move it over into just being part of the fee schedule to making things just a little bit more part of daily practice.
Okay, so some important kind of shuffling in what services bring in the public sector and so forth. Again, broadening access to these. Patrick Conway to close, just a sentence or two, Patrick. Next generation, what is it?
One, keep it simple. The example I gave, green, you get a check for $100. Red, you write a check for $100 today. That's simple. People can follow that. Two, I agree on lifestyle prevention, healthy behaviors. Three, test and learn quickly, which was said. We got to test and learn quickly and then make things permanent, as Kavita mentioned. And then four, it's got to be embedded in a system of care. The system matters. So how do we embed it in a system of care focused on the quadruple aim?
Got it. I hear your CMMI mission when I hear test and learn quickly. So that's carried over. So thank you. Well, look, we started this out with four swell, true pioneers in Karen Ignati and Jim Parker and Kavita Patel and Pat Conway. We couldn't have done better for a kickoff. And by the way, when we talk about the next generation VBID, that is to include you four originals. So you can't go anywhere without us. Thank you all very, very much. Great start, all four of you. And we're now going to move to our next panel.